Well, good afternoon, everyone, and welcome on behalf of Trust for America's Health. I'm Megan Wolf, Senior Policy Development Manager for TIFA, and I'm joined here today by my colleague, Dr. Karan Phillips, our Policy Development Manager. We appreciate you for joining us this afternoon for our monthly age-friendly public health systems training, all presented with gracious funding from the John A. Hartford Foundation. Next slide, please. So during the presentations today, we're going to ask that you please keep your microphones muted. During the question and answer session a little bit later, you will be able to unmute yourselves to ask questions and interact with our speakers. And we also encourage you to submit questions throughout the day, throughout the presentations through the chat function, and we'll capture those and hopefully have time to pose all of them at the end of the presentations. Next slide, please. For those of you who are somewhat new or completely new to this series, Trust for America's Health, or TIFA, is a policy research and advocacy nonprofit dedicated to optimal health and well-being for every individual and community. Our age-friendly public health systems, or AFPHS, training series is part of our initiative to elevate healthy aging as a core public health function, and it's designed to increase the capacity and expertise of the public health and aging services community on the public health roles in healthy aging. This year, our AFPHS trainings have been focused on the social determinants of health, and we're pleased today to welcome representatives from 3 state health departments who will share information about the development of their data systems on older adults and how they are being used or can be used to address the social determinants of health. But before we turn to our guests, we wanted to provide just a little bit of context for older adult data and aging profiles. So I'm going to turn to Karan now, who's going to go through the next few slides. Karan, you're on mute. There you go.
I was looking for the mute. Thank you, Megan. So again, we wanted to just set the context, and I should always disclaim I'm a little bit of a data nerd, so I get excited about these topics. But one of the most important uses of data is sharing and developing interventions, building collaborations, advocacy, identifying inequities, and targeting resources. So we have a diagram here that shows some of the potential partners for data sharing, as well as partners for data input. These include public agencies, community organizations, schools, health-based organizations, and some others, just to give you an idea of the limitless opportunities for partnerships and data. We're also going to, I'm actually going to let Megan go through this and then I'll come back, but we're also going to highlight again our Florida charts and aging profiles, and we will also have a video from some of our colleagues in Florida to highlight this information as well.
Can we do these slides, Karan, after the video? I think that might make more sense. Yeah. So if you could just scoot forward to the slides you were going to do, that would be great. Thank you.
I will actually then skip over to some additional information. And I should note, we have James on the line with us. So James, I will invite you to chime in if if there's anything you want to add about some of these profiles from UMass. But we also wanted to talk about the value of having profiles. So these couple slides are from Dr. Elizabeth Dugan from the University of Massachusetts. And her team at UMass have been developing profiles, and more specifically have been developing profiles with our colleague, Dr. Keena White, who you'll hear from later on in our training today. And they have the Massachusetts Healthy Aging profiles, and they've also developed profiles in other states, and we're going to go through these examples. So one of the key things that Dr. Dugan shared with us about developing these profiles is that there's no one cookie cutter way to build these. Every state is obviously very, very unique and have their own challenges and subsequently needs for different data. And these can vary from health assessments to interventions, advocacy, and media attention. There are many partners in this work, so you'll again hear more about this as well. So here's an example. You can see this is an Alzheimer's disease and related dementias map. The red depicts communities where targeted interventions are needed, including respite services, adult day health, memory cafes or clinics, and safer pedestrian crossings. So again, highlighting this information may present an opportunity to share with a potential partner about these are some of our needs, and this is where our demographics are related to Alzheimer's and related dementias. And again, you can also developing strategies and approaches and interventions to helping these target populations. And then we have another example. This is the Healthy Aging Data Report with graphics and a call to action. And again, we're going to see some additional examples like these from our speakers. So I'm going to go back to our video. Apologies, my video is here. I'll put it, there we go. So we're gonna play about 6.5 minutes of a video from our colleagues in Florida, where they're gonna highlight, again, not only the context for social determinants of health and how they can be used to address data, but also, again, start gearing us up for our first set of featured profiles, if you will, about Florida.
Ron, I'm not hearing any sound. I don't know if it's started to play.
Hello, everyone. I'm Sherry Creel, and I work at the Florida Department of Health in the Division of Public Health Statistics and Performance Management.
I'm Joanne Steele, and I work with Sherry. Together, we work on a website called flhealthcharts.gov. And we're here today to bring you a webinar about social determinants of health and health equity. We hope you'll find it helpful.
Today, Joanne and I will be covering the following objectives. What are the social determinants of health? Where can I find social determinants of health data? And how can I understand the significance of different social determinants of health? So let's begin with what are the social determinants of health. Healthy People 2030 defines them as the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health have a major impact on people's health, their well-being, and quality of life. They also contribute to wide health disparities and inequities. Joanne, please tell us some more.
Well, Healthy People 2030 classifies these into 5 different domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context.
So where can I find the social determinants of health? Let's look at the Centers for Disease Control and Prevention at a couple of their surveillance systems. First one is the Youth Risk Behavior Surveillance System, YBRS for short. This system monitors 6 categories of health-related behaviors that contribute to the leading causes of death and disability among youth and adults. If you look, here are the selected topics that they cover. And on the left-hand side, you can look at the data by United States, your individual state, local school districts, territories, and tribes. So let's take a look at one of the topics, unintentional injuries and violence. On here, let's take a look at one of the school safety concerns. Students who did not go to school because they felt unsafe on their way to or from school or at school. So if you notice on this view, you're able to look at a subgroup of race, grade, sexual orientation, and sex. Let's take a look at the race category. Here, if you notice for this particular indicator, the United States, the population, American Indian and Alaska Native has 24.7% of their students who did not go to school because they felt unsafe at school or on their way to and from school. If you wanted to compare a couple of these race breakouts, you can just click this button, and you will find if there is a statistical difference between the two races. Also, there's a handy export feature if you want to look at the data a little more in detail and do your own analysis. Another place that the CDC has that you can look at is the Behavioral Risk Factor Surveillance System. Here they have classes which include alcohol consumption, fruits and vegetables, HIV/AIDS. Let's look at the healthcare access and coverage and healthcare costs. The question they have there is, was there a time in the past 12 months when you needed to see a doctor but could not because of costs? They have a map that you can click on the data for your state, click on the state and look at the data for your state. For Florida, 14% of the adults did not see a doctor in the past 12 months because of cost. If you want to see the data broken out into a table, a bar chart, you can click this button and see that comparison. If you want to look at the table of data, you click this button, and here's the view you'll see. Also, if you want to export the data, you have these available options. So Joanne, do you have some resources to share?
I sure do. Let's see. Those are great examples you gave, Sherry, because most states participate in those national surveys, and one covers the youth and the other covers adults. And while we're rich on outcome data, like from vital statistics, it's harder to get that social determinant and behavioral kind of data. So now I'd like to share some information from the County Health Rankings, America's Health Rankings, and the U.S. Census Bureau's American Community Survey. The County Health Rankings and America's Health Rankings show how counties and states compare to each other and how they compare nationally. Also, America's Health Rankings has a special report focused on disparity. County Health Rankings provides a model that shows the influence of the social determinants of health on the outcomes. You can see by the graphic the great influence that it has. This they call the social determinants health factors, so it's right here. On their website, you can interact with the data live, or you can download a PDF. And for today, I downloaded just a page or two out of Florida's to show you. Here's an example of what you might find. They'll rank in the county health rankings, they'll rank all the counties in your state by health outcome and by health factors. They supply the data source and the weight for which each of those is scored to come up with this ranking. And then the thing I like to do is look at the data sources and explore those websites to find more data that might be of interest.
So we are thankful to our Florida colleagues for sharing that information with us. And now I get the privilege of turning it back over to Megan to talk more specifically about Florida, and then we will have our two other featured speakers share their information as well.
Thanks, Karan. Yeah, we're really thankful for our Florida data experts, and Sherry and Joanne really are data experts. They're responsible, or part of the team that's responsible for creating the Aging in Florida profiles on the Florida Health Chart site. And they're in the process of updating that data as well. They've had focus groups ongoing throughout the first part of this year, and will be coming out with a completely revised Aging in Florida profile by October, I believe. So we wanted to show what it looks like, what the Aging in Florida profiles look like. And these are available for all 67 counties in the state. And so you can see on the top navigation panel there, the categories of the data that's available by population, family and living arrangements, education and financial status, and health status and behavior. So next slide, please. And that data is also broken down by race and gender. So the first, so keep clicking, yeah, right there. So this chart is the health status and behavior section. And you can see that they track general health status, but also smoking, obesity, access to health providers, and so forth. And so this data can be really helpful to identify social determinant issues like availability of healthcare, and where additional community changes may be needed to improve physical activity for older adults or accommodate older adults with disabilities. And then click one more forward, and we'll overlay another chart here. So this is, again, more information about disabilities, Medicare enrollment, those who received a flu shot, fall-related injuries, and so forth. So this data, again, is available for every county in the state of Florida. And I encourage those of you who do not yet have older adult data profiles in your state to take a look at the Florida profiles. Again, they were the first of their kind, I think, and they are constantly being updated. And we will definitely provide the website. Thank you, Laura. We'll definitely provide a link to that website in the chat as we move through the presentations today. So I'm going to turn over now to our two speakers who are with us today. We're going to start with Marcy Getz with the Washington State Department of Health, and then we'll have Dr. Keena White with the Mississippi State Department of Health. So we are going to turn it over now to Marcy. Marcy, welcome.
Thank you so much. Good afternoon, everyone, and thank you to the TIFA staff for inviting me to present today, and to all of you for joining us. Karan, can we go to the next slide? So Washington State applied for and received in the Age-Friendly Public Health System State Expansion Grant. So in some of my slides, you're going to see, or on this one even, AFPHS, and that again stands for Age-Friendly Public Health Systems. So we were fortunate enough to receive that grant, and it's been a wonderful opportunity for us to work towards creating age-friendly public health systems at the state, local, and tribal levels. It's also given us the chance to meet and work with folks from across our state who work or volunteer in a wide variety of areas. Next slide, please. I'm going to be on this slide for a minute. I know it's got a lot on it too. So today I was asked to talk about creating our older adult health county profiles. And so I just want to give you a bit of context about what led to their creation, and then I'll talk more about the profiles and how they're used and who's using them and what are some of our limitations with them. So before diving into the details of these profiles, I also just want to thank TIFA and the John A. Hartford Foundation for providing the support and funding that allowed us to create these. And this truly was a team effort involving TIFA staff, Dr. Karan Phillips and Megan Wolf, and my Washington State colleagues, Lynn Cordy, Jamie Tudeberg, and Jana Barty, as well as our wonderful analyst, Nils Franco, who worked for Alterum. Early on in our work with TIFA, they introduced the Washington State team to a nonprofit, Alterum, who work with federal and state health agencies and foundations to improve health outcomes of Medicare and Medicaid beneficiaries. Through their work, they had access to Medicare data, and we were very excited because they felt that they could share that data with us. And often Medicare data is costly to obtain. So as part of our Age-Friendly Public Health Systems grant, we plan to reach out to local health jurisdictions, tribes, and area agencies on aging within our state and invite them to apply for a small grant funding and to become members of our Age-Friendly Public Health Systems Learning and Action Network. This team decided it was important to have county level older adult health data. We knew we had to make the case that age-friendly public health systems work should be a priority, and this data would help inform decision-making, especially at a time when public health was stretched so thin due to the pandemic. And we were asking folks to take on a new initiative. We ended up creating older adult health county level profiles for all 39 counties in our state. So prior to moving, and I'll just tell you that if you're looking at this slide on the right, on your right-hand side, is like what the front cover page looks like. And they're 4 pages. And I want to just share a few more things before moving on to more details about the profiles. That our team would have liked to include race and ethnicity data, but the Medicare data sets offer race and ethnicity in Medicare claims, and race, but their race and ethnicity analysis would be a great and valuable next step, but there were 2 considerations that made it more challenging for us and why we weren't able to do that. And one is that Medicare's race information is more limited compared to state standards at a state level. So oftentimes you will get you'll get data about a race or around a racial or ethnic group, but then it is not defined more granularly so that you can act upon that. And also because of the small population sizes in many of our counties in Washington state. I do want to say though, that Medicare data sets, while they provide a robust set they do provide a robust set of data about healthcare use and chronic conditions, they do not address the social determinants of health, such as socioeconomic status, neighborhood and built environment, education, access to quality food, and others. So they're not asked at this point, but there are efforts to change this. That being said, the data provided, especially around chronic conditions, emergency room visits, and falls, are greatly impacted by social determinants of health and provide openings for counties to begin exploring the social determinants of health as it's related to older adults. And I also just want to highlight that it can also be beneficial to use the social determinants of health thinking shared in the March Age-Friendly Public Health Systems Training, Healthy Aging and Social Determinants of Health, presented by Dr. Aaron Guest. If you haven't seen that presentation, I encourage you to do so. It is on the TIFA website. And social determinants of health thinking is doing the work that addresses and operationalizes social determinants of health, how to act on these. And I'll talk a bit more about this in a future slide. So if you could go to the next slide, Ron. So we started, well, first of all, I wanted to just say, to tell you is that each profile has the same categories, but the data is specific and was run to that county. So, you know, in each one of them, they may look alike to you, but they were run with their own data. And so what we decided to do is—
among all of this troubling data, there is some good news. There are evidence-based programs that we know can prevent substance misuse and suicide.
I'm not sure what that was. Sorry, that wasn't me either. So anyway, so anyhow, I won't be going through the data in each of the categories, but I wanted you to get a sense of what we included and then how it's been used. So the profiles start with data regarding the current population size of those 60 and older in each county. And we also wanted to call out though, the projected future growth of those 60 and older, and then also the growth of the population 85 and older, as that will help public health and our partners at area agencies on aging to plan and be strategic for the future and to see that the population size of older adults is growing and how do we support people to live the best lives they can. Next slide, please. So all of our profiles include chronic conditions, and we picked the top 6 that had the highest percentages, and we talked about sort of where things are now in terms of priority, in terms of, for example, in Spokane County, which this is from, hypertension was the #1 chronic condition for people 65 and older in 2019. And then we talked about what would be the growth of that by 2040. So preventing or mitigating the impacts of chronic diseases through the life course is the work of public health, and it impacts the quality of life, especially as one ages. And research continues to emerge about potentially modifiable risks related to brain health including chronic diseases such as diabetes and hypertension. Next slide, please, Glenn. We wanted to look at emergency room visits. This data, like all the data in the profiles will give people an opportunity to do planning and to think about their interventions. But we also just wanted to talk about ER visits because there's a lot of information in each of these profiles for counties about action that they might be able to take or put in place, initiatives or processes to help mitigate the need for the use of emergency rooms by older adults. Next slide, please. And then, of course, we included falls and fall-related injuries because they're a major area of concern and poor health outcomes for older adults. And it's a major area of concern for public health and those of us who serve older adults. I'm just going to use an example from Dr. Guest, as he noted in his March presentation. When he talked about social determinants of health thinking, they can be used he gave a great example about how to use this among falls among older adults. So the profiles that we provided talk about the downstream impact or the numbers of people who've had individual falls. But then this data can be used to look at risk factors for impacting falls, such as access to services, building design, etc., and upstream levels such as education, housing, employment, place of birth, those kind of things. The numbers of people who experience falls or fall-related injuries can prompt a deep dive into the mid and upstream factors related to falls, and from there, action steps can be taken to decrease numbers of falls and therefore be included in social determinants of health. Next slide, please. And then we wanted counties on the county level to know about the key subpopulations that will grow, because again, that's needed to strategically plan. And I'm just going to tell you, because you might not be able to read this, that we had 3 subpopulations, and I just want to tell you about how we define that, which was people age 60 or older with a disability. And we define that as an ambulatory difficulty, walking or climbing stairs, or self-care difficulty, dressing or bathing. And cognitive impairments was another one, and it's defined as difficulty concentrating, remembering, or making decisions. And the third one was instrumental activities of daily living, and that's defined as difficulty doing errands alone, such as visiting a doctor's office or shopping. And many of these definitions were provided for us by our analyst, and so that we can understand how the data he was sharing with us was defined. The next slide, please. So we couldn't possibly be in public health and not tell people their next steps or actions they could take. And one of the, just a couple of the things is that they, wanted to let people know, okay, well, now I have this data, what do I do? And it could be some options were convening to develop an action plan with your community partners to incorporate data into current communication efforts, which I know we have been doing at the Department of Health. Evaluate current public health programs to ensure evidence-based programs are used, such as with fall prevention curriculum. And the other big reason we wanted people to take hold of was to join the age-friendly public health systems learning and action network that we have begun. So could I have the next slide? Oh, and then I'm sorry, and the next slide, data sources. Again, we can't be in public health without providing good quality data sources. Next slide. So you've seen now what was included in the county level data profiles, but who's using them? Well, our members of our Learning and Action Network are using them, and they're members of local health jurisdictions, area agencies on aging, a tribal health consortium. But I was also called by the Rural Health Office and the Office of Community Health Systems at Department of Health, who wanted to share them with all the rural counties they worked with. Universities wanted them to inform their research. And also we shared them with our Age-Friendly Public Health Advisory Committee, other states such as Tennessee, and recently with AARP in our state. So I'm continually letting people know about them, and the more that people know about them, the more they are reaching out and asking for them. So it's really exciting. Next slide, please. So how have they been utilized? So I can't really tell you how they've been utilized by other people other than our age-friendly public systems learning and action network members, because I asked them. And I'm really excited about their answers, but other folks that have obtained them, I haven't heard back from them about how they've been utilized. So for our group, they've been used to communicate the importance of age-friendly public health systems to executive leadership, and that's really important. It's really important for public health to make the case. Most of our work has not been on older adults' health, and most of our work has led to older adults being healthier throughout the life course, but we haven't been as present in this topic as we are right now, but we need to continue to bring others on board. And then to inform community health and needs assessments for the future, so that more of these topics are asked when those assessments are done, to inform decision-making by coalitions, to help identify gaps in data, to inform strategies and tasks, and to support funding applications, and really to paint a full picture of the growing needs in different counties or regions. And then also some folks are using them as part of trainings, especially when they're doing fall prevention and training and hospitalization information, use of hospitalization in trainings. And then also people have used these to develop their age-friendly public health action plans. So everyone who's a part of the network does do these. And a lot of them, sorry, my dog is barking in the background. Many of our age-friendly public health systems participants have used their county level data to help inform their action planning. Next step, please, or next slide. So I asked people, in addition to my own thinking about this, what data is missing? So some people said they would like more of the specific data in each category for adults 80 and older, more information about emergency response calls, definitely information about race and ethnicity, and then data that's focused on social determinants of health, like that are listed up here in terms of like socioeconomic status, built environment, access to housing, food security, and those kind of things. One of the things that I think is important to note is that before this, doing this profile, most of our data came from BRFIS, some from the CDC, and some from the census. So we still have those to also look at, but we also have something called the Washington State Tracking Network, who does do some information about social determinants of health per county. And for example, I was able to look up age 65 and older, and what percentage of people in a certain county were living in poverty. So we have more work to go. I'm excited for us to maybe develop a system like Florida's or other systems. But what I am excited about is that people have this information, and it's starting discussions, and it's helping people to dig deeper. Next slide. I think that we're saving those till the end. Is that right, Karan? Okay.
Feel free to put them in the chat as well. Yeah, we have a set Q&A at the end.
All right, perfect. Thank you so much. I'm all set.
Great, thanks so much, Marcy. And now we'll turn it over to Kina. Dr. White, take it away.
Sure. Good afternoon, everyone. And thank you, as always, to Trust for America's Health for the opportunity to join the team today. Similar to Marcy, Mississippi was also awarded the Age-Friendly Public Health Systems funding opportunity. And so with Dr. Carmody and John A. Harford Foundation, we're always so appreciative of their support. Next slide, Karan. So Mississippi is a centralized public health system. And so we took a slightly different approach to our healthy aging data profiles. So I'll explain how we created this exciting partnership with University of Massachusetts Boston to establish our profiles. But one of the things that we did when we received our funding for age-friendly public health systems is we used a collective impact framework to first determine what was our vision for this work. And we wanted to just make sure that in Mississippi, healthy aging was equitable, and we wanted to make sure that it was a value adopted for all Mississippians. One thing that we did notice is that our older adult population was often the least prioritized in a lot of our state level work. And so with our age-friendly public health funding, it allowed Mississippi to really create a voice beyond just what was happening with our state unit on aging. So public health is really excited about that. Next slide. So in Mississippi, as we thought about how healthy aging data could really support what we do, there are a couple of areas that stood out very early on for us. Service development, similar to what Marcy had shared, we have always had access to our vital records data and our data that looks at morbidity, mortality, but specific to the older adult population, it was very segregated. So we did not have this centralized source of information. We had county level data profiles available on our website, but again, they never really prioritized the 65 plus or even the 60 plus population. And so starting to look at those needs for exactly what interventions, what evidence-based interventions or best practices were needed for the older adult population, and then also looking at our collaboration opportunities. With our age-friendly public health work and knowing the data that was needed, we were able to begin those conversations with our AAAs, also our state unit on aging. Our AARP chapter was very excited to collaborate with public health to have that conversation about what was missing in terms of the data here in Mississippi. And as many know, we are a very rural state. And so we had an opportunity to collaborate with our rural health partners and even looking at our state rural health plan and trying to assess exactly what gaps were presented and then what opportunities our age-friendly efforts could bring to develop these healthy aging data profiles here in Mississippi. We have organizations that support our mayoral health councils. We actually have one of our community health directors on the training today, Brittany Mosley. She's worked to help establish mayoral health councils. And so understanding the need for data as we meet with these individuals to explain the value of understanding how these interventions need to be addressed specifically for those individuals. Faith-based institutions. We understood very early that in our communities, there are certain champions that we really need to provide the education to, because they are the ones that are actually helping connect these older adults to the resources that they need, the access to care and these determinants. Without these champions, these communities may not embrace the information that is shared. And so we knew that having this data to educate our faith-based congregations was going to be very important. And lastly, advocacy. Being able to really make the case for public health and the support of older adults is very important. There is funding that does exist, Older Americans Act funding and others, but really making the case for state level funding to support older adults is an ongoing need. And so those are sort of the pillars of what we thought was very important for the domains for public health here in Mississippi. Next slide, Karan. As we think about social determinants of health, and our colleagues already shared the Healthy People 2030 framework, one of the areas that stood out for us is really looking at our healthcare system and our coverage needs for older adults. We have low rates of geriatricians here in Mississippi. Access to transportation needs for our rural communities remains a challenge. And so looking at the data that we needed to have these conversations, our profiles the existing profiles simply didn't answer that. And so I want to give a shout out to James Fuchian from Massachusetts, who's on the call. James and UMass developed healthy aging data profiles, and we were blown away with their ability to really look at those social determinants of health. And so James introduced me to Dr. Beth Dugan at UMass, and we had a couple of conversations, and through kindred spirit, we are now collaborating to create the first kind of older adult profiles for Mississippi. And they are a very robust way for us to be able to share this data information. Just from a historical standpoint, we have presented to our state leadership who has embraced being able to have these profiles here in Mississippi. The data that we will utilize to populate these profiles include ACS data, the BRFSS survey, as well as CMS data, because we wanted to make sure, as Marcy mentioned, some of those gaps that are currently existing in profiles that relate to those determinants, we wanted to make sure that we had that information. Thank you, Megan, for sharing that. And so next slide, Karan, I'll share my screen and show you a couple of the profiles. But in development of our profiles, when we presented to senior leadership, we wanted to make the case for why it's important to look at our older adult population. In Mississippi, we have designated retirement communities, as other states, but we always have this assumption that older adults only live in those retirement communities and that this is not a statewide need. And so if you look at the map on the left, if you look at the density population, there is an older adult in every county of the 82 counties in Mississippi. So although we have clusters of older adults, it's not an isolated need. There is a need to provide access, to provide economic security, to provide affordable health care, and to ensure that health literacy is available for all of these individuals across our state. And so we know that there is a huge need to be able to have this data at the fingertips of our leadership to make these health-informed decisions. Next slide. So one of the things that Marcy also shared is that very limited opportunity to include equity in our work. Dr. Beth Dugan, as we look at our county level profiles, we wanted to make sure that we are looking at our inequities. So as our data profiles are being populated, we're actually looking at that granular level to see for our older adults, where are the challenges for inequities in Mississippi? I will say that one of the areas that we very often realize is their ability to access broadband connection. We noticed an increase in telehealth access due to COVID, and we also understood that for a lot of our older adults, they are simply not utilizing the communication technology that we assume. They're not on a website. They're not using a smartphone. They're still using traditional forms of communication for information. And being able to look at our profiles and understand how close these individuals are to a grocery store or a library or a source of connection is very important. So we're excited that within our profiles, we will be looking at those disparities and inequities at a granular level. Next slide. So for Mississippi, I'll show you the profiles, but these are sort of very key elements that we are looking for as we build our profiles for the older adults. We want to build capacity at the community and population level. We know that that capacity is currently missing in a more aggregated way. We want to make sure that we have this network of coordination. It is very exciting to work side by side now with AARP, our AAAs, our State Unit on Aging, and all of our older adult advocates. We had an opportunity in May to present at our Public Health Association conference, and we received an overwhelming amount of support for individuals wanting to participate and provide support to older adults in Mississippi. And they were waiting for the data to do just that, to really understand the needs. And so now our next step is to release our first statewide work plan for age-friendly public health, and also in the fall, release our data profiles. So it's going to be very exciting to have this robust amount of information to really address these health outcomes. Karan, if you can let me share my screen, and James is on the call as well, but I want to show you all a copy of the profiles that Massachusetts developed. And the reason this is so key is because we felt that what Massachusetts had could really benefit us here in Mississippi. If you look, they do a phenomenal job of expressing all of the population characteristics for each county. And so for the older adult community, you'll see, again, race, gender, marital status, but Marcy made a point about education and income status. That's important so that you can really understand for each county what those determinants are and those demographics are. So population characteristics is a key foundation of the profile. Looking at the healthy aging indicators for wellness and prevention is very important as we understand who's been vaccinated, who's not been vaccinated, and being able to target those intervention efforts at the county level is key. Nutrition and diet. Mississippi is one of the most obese states in the country. And so we understand that we need to be addressing comorbidities as we're working with our older adult population, because they typically will have one or more chronic conditions that we should address. as well as behavioral health needs. With COVID and post-COVID, social isolation, social connectedness has been a significant need for older adults. And so looking at the profiles that Massachusetts developed, we are working in collaboration with mental health here to really include those indicators so that we can work closely with those partners. Chronic disease is also an indicator that will be included on our profiles. And these profiles, again, are available in your chat that you all can see for Massachusetts. Access to care as one of the determinants is included on the Massachusetts profile. And we have several opportunities now with a new funding from CDC for Alzheimer's to really increase the number of memory cafes in our state, and having the data to really show where they currently exist and where there is a need to expand has been very important for our work in Alzheimer's and related dementias. Service utilization, as Marcy mentioned, for ED visits, being able to truly understand how our older adults access primary care if they live in a rural community where they may not have a healthcare facility, how are they really receiving those services? And so as we continue to grow in our efforts, we are leaning on those experts like UMass and Florida, who have really taken a lead in establishing the best way of presenting this data. And so for Mississippi, we're really excited. Our profiles are very close to being complete. We gave a soft preview to our state leadership a couple of weeks ago. So Dr. Dugan and her team have been aggressively working with Mississippi to really move this along. And so we're really excited. And our next steps after we release our profiles is we're actually going to have an in-person convening. Being able to look at the data from a health equity inequities lens will allow us to create a social justice convening for older adults in Mississippi to really talk about the gaps in our data and the need for addressing that support. So we're very excited to have this collaboration. And I always thank James Fushian, because without Tifa and the team, we probably would not have gotten connected to UMass. And so Mississippi is very appreciative of this opportunity. And similar to Marcy, we'll be open for any questions.
Great. Thank you all so much for those wonderful presentations. And I think that it has stimulated a lot of conversation in the chat. Karan, let's go ahead and take the slides down so we can see each other while we're doing Q&A. And there is one question that was posed in the chat, and this is for Marcy. Marcy, has Washington been able to find or create a data source for food insecurity by county for the 60+ population?
And I did I have the person's email and I'll follow up with them. I believe there is, but I don't want to say, I think through the Washington State Tracking Network, we can look at that, but I don't want to commit to that without knowing for sure. So I told them I would definitely email them.
Great.
Let them know. And I think probably my colleagues, just as another note, is my colleagues in this SNAP Ed program are working hard to look at this issue amongst older adults and have been applying for funding. So.
Great, thank you. And so are there any other questions? If you have a question for Dr. White, for Marcy, for us at TIFA, for Florida, we can certainly, although we don't have the Sherry or Joanne here with us today, we can certainly pose questions to them and have them answer and share those answers with you as we follow up with you. But if you have a question, you can raise your hand or feel free to just unmute yourselves and ask the question.
So I will make a comment, Laura Vanderhill. Yes, absolutely. The Massachusetts profiles, although Mississippi, our profiles are in the final stages of development, we were actually able to showcase the Massachusetts profiles as a blueprint for some of our grant applications. And we were actually able to work with some of our local communities and help them develop their community health needs assessments using that blueprint. There is a Healthy Aging and All toolkit. Megan, I don't know if we can share that as well in the chat, but there's a toolkit that James and the UMass team shared with Mississippi, and we actually use that toolkit at the local level, meeting with our key constituents to really see what needs our local communities have for older adults. So even though our data profiles are still in development, we were able to collaborate with other partners to still provide those great resources.
Great, thank you. Thank you so much, Kina. And we'll definitely share a link to the toolkit as well when we do the follow-up email to everyone. So, so we'll be sure and capture that. So I also wanted to mention that when Karan and I were talking with Dr. Dugan from UMass a couple of weeks ago, she is willing to, you know, kind of help anyone who would like to get started in this process. So if you're interested, you can reach out to us, respond to us, and we will connect you with her. The process may not be completely free, but I think that you know, funding is certainly available, and we at TIFA are happy to help find funding for this process if there is going to be a cost to you. Grant makers and aging have a number of regional and local funders who are really wanting to get involved in this area with public health, and so are always looking for ways that they can support this work. So please reach out to us if that is an interest that you have. And James, I don't know if you're still on. I know Kina has mentioned James Fuccione several times. James is with the Massachusetts Healthy Aging Collaborative. I don't know, James, if you're here, if you want to come off mute and just, we just want to acknowledge you and the work you're doing, but also if you have any additional thoughts about how the data is used in Massachusetts. I know I'm putting you on the spot here, but how the data is used, and if you have any other thoughts about these data profiles.
James unfortunately had to hop off at about.
Okay, all right. Well, we'll catch up with him another time.
I did want to also highlight that we have another training that James actually led back in, I believe that was May. That also is available on our website and on our YouTube channel. I'll get the link for that.
Actually, I already did that, Karan. I put that in the chat just a little bit ago. Yeah, when we were talking about technology. So, are there any other questions?
This is Marcy. I also wanted to say that some of our partners are on the phone, are on the webinar today too, who've been wonderful, who have been working with us in our Learning in Action network. So just wanted to shout out to them.
Great, thank you. So I really appreciated, Marcy, when you shared too about the data that you still need and that you would like to have and you know, and find useful. So I'm wondering if anyone else has ideas about the data that is not available in your state or your, you know, within your system, and if there is data that you would like to see.
Jane has her hand raised.
Oh, go ahead, Jane.
You know, Megan, it was kind of like your question. I was just thinking about this and thinking about this wonderful information that's available and how it will help understand, assess, and improve, you know, the lives and the healthy, the health of older people in your communities, your states. I was just wondering, to your point, Megan, are people excited about this? It sounds like people are asking for it. It's not something that they say, oh, well, okay, that's fine, that doesn't help me. Just wondering how it's been received and accepted or demanded, you know, at the state and county and community level.
Good question. I think that's for Marcy or Kina or both.
Well, I was just going to say, does anyone, I don't want to put anyone on the spot, but anyone that's here from Washington want to respond to Jane's question that's part of the Learning in Action Network?
Hi, this is Mary Pat O'Leary. And I would say that what we do is we utilize the information, and I heard this on a webinar, so I can't say I coined it. And you go with the kind of the idea of what, so what, now what? And I think this is really important for us when we're synthesizing data. And let's take falls. So we have a bunch of information about falls. So what? Are we going to focus on specific older adults, those that are 85 plus, those that live in senior housing? And so what? And then what we did is we actually collaborated with community-based agencies that offered fall prevention programs, evidence-based programs in senior housing buildings, in some of our like SHA, SHAG, King County Housing Authority, and then really looked at the ability to track the improvements for the stability and the balance and the strength, and then also say,
once you get someone's toe into evidence-based programs and they start realizing, hey, I could do something else, then you give them the menu of other health promotion programs, like maybe senior drug education, maybe health promotion, living well with chronic conditions. Thank you.
Thanks, Mary Pat. That's great. Yeah, and I love the what, so what, now what. I think that's a great little snippet, but it's so wise. There's so much wisdom there. Any other responses to Jane's question? There is another question in the chat, so I can raise that one.
Megan, I will say in Mississippi, and Dr. Phillips to speak to this, we were well received with our presentation for age-friendly public health. I mean, we had so many cross-sector partners, from our transportation leadership to medicine, I have a meeting next week with our pharmacist director for the Division of Medicaid. There is so much interest in what we're doing for the needs of older adults. And it was surprising. It was very surprising. But again, I always say we're complementary, not competitive. And so when we come to a table, we're not trying to replace or duplicate what already exists. We're trying to identify where the strengths and needs are for public health and provide that void, fill that void. And so I will say in Mississippi, there's been a strong appetite for this work. And so we are having individuals asking, when will the data profiles be available? And so we're trying to get those completed as soon as possible.
Great, thank you. And that leads to the another question was, were there any surprises from the data, right? Like what did you learn? And we know that in Florida, there were a lot of surprises. People were surprised about, I remember one county when they first looked at the data about falls, they were surprised about the number of falls. And so they were able to strategize and develop interventions for the pre-65 population to build balance and strength in that population to prevent the falls as people get older. So I think that's one way to think about it, and to take that surprising data and put it into that kind of strategizing. But Marcy or Kina, were there any surprises for you all?
I will say for the Alzheimer's and dementia data, one of the surprises that our academic medical center director mentioned to us is that there's always this assumption when you see sort of a high mortality rate for a specific county, that it's because they are not doing enough for that population diagnosed with that condition. And what the data allowed us to do was have a deeper conversation to talk about, well, actually, the reason there's a higher rate of mortality for this county is because the majority of the individuals with that diagnosis are being treated in the facilities within that county. And so it allowed us to have a deeper conversation about, you have to understand the data and not just use the numbers themselves, and really have a conversation about the data. So it allowed us to really be able to educate individuals on not just the numbers of what you see, but understanding the context behind those numbers. And yes, a county may be considered a hotspot because it has a higher level of mortality, but really it's because that county provides greater access to care for the individuals being diagnosed. And so it just provided a great educational opportunity for those that were at the table.
Very interesting. Thank you.
I would say I'm going to go back to the other question, and one in terms of using the data. What's been really exciting to me too is my colleagues in public health have been taking this data back and sharing it with their broader group of colleagues. And so people who might not have seen the connection between older adult health and their work are now seeing it. And I think that their involvement in Learning in Action Network and the access to the profiles helps people to be able to see their place in this work.
That's great. And I think that that's so true, that, that data opens eyes and it opens doors. And so I really appreciate that. And we really appreciate all of you attending today. Great presentations, great questions, great interaction. Karan, I'm going to turn back to you to close us out here today.
Thank you, Megan, and thank you, everyone. Thank you to our speakers. Again, I am a bit of a data nerd, so this was always exciting for me. Just to close us out, our next training will take place on August 18th at 3 p.m. It's always the third Thursday of the month, and you can register for this under events in the coming days. And this is for anyone that is viewing a recording of this training. If you are viewing this as a recording, please pause the recording at this point to complete the survey, let us knowing that you completed this training or viewed this training. Also, a little link will pop up in the corner as well for you to navigate to the same survey to, again, indicate that you've completed this training. And we thank you all for attending today.
Thanks, everyone. Hopefully we'll see you next month. Take care and happy data mining.